Are any of you using the guidelines derived patient materials to help patients in the education? Dawn, have you used those at all?
So the NCCN patient guide is a fairly new document. I don't have any personal experience, and I don't have a lot of experience with patients using it since it is so new, but I have looked over it, and it's a pretty extensive document, has a lot of good information for patients, and it's easy to read.
Good, and there's also a mobile app that I think
Yes.
has just been released. And we talked earlier about the, calling patients, and I think in the future, as technology has been evolving so rapidly, that we might have mobile solutions where we can interact with patients and hopefully get some information right away without having to make that call, and put to some extent the locus of control back into the patient's hands and allow them to communicate with us. I think that'll be exciting going forward. Have you guys used any patient education materials that you particularly like?
We've come up with our own. Basically, we look at everything that's provided from the various organizations and sort of filter down to a patient level what we think our patients can understand. And the basic point is to stress communication. I mean, we reach out to our patients a lot, and we're able to because we have the staff to do it. But that really is what helps guide us going forward. We'll intervene day 2 if necessary. We'll say, listen, we're going to get you some medication here to help you going forward for this cycle, and then look at it again when they come back in. But holding their hand is really important, and that's kind of what we're thinking about. We're really holding their hands through this really important phase.
Something I learned from my nursing colleagues is I like how Howard, you've individualized that a bit more, is to really assess how people learn best. There's so much information thrown at us, especially cycle 1, that people are just full of info they can't take anymore. So I'd like to stop and say, do you learn best with numbers, pictures? Do we need to talk this out? And then revisiting it, the repetition is real key.
What we've found over time, and this is just counseling in general, is you overwhelm people easily, and we really summarize things down to 3 points, not 4. 4 gets lost. But 3, if this, or this, you need to call us. These are the 3 things really important about this specific treatment.
Yeah.
Call us. We'll be happy to talk to you. That's what we're here for. And it tends to work. We do get calls, and those calls are specific. You told me to call because of, nausea, because of vomiting, because of whatever, and that's why I'm calling you. Great. We can help you with this.
I think that's a great point for our audience. I mean, cancer treatment now is so complicated, and we've already talked about the fact that physicians are focused on the actual therapies and what the response is going to be. And then you add on supportive care, and there's so many things for patients to think about. And they immediately, as soon as you start talking about cancer, 75% of what you talk about, they don't hear. So keeping it simple, although our tendency is we want to give them all the information, but keeping it simple is a very important point so that they can respond to that, because there are so many pieces of this.
Yeah, we give out information, and it's complete, but we highlight the things that are really, really important here. And that's kind of the way we like them to look at it.
Repetition and reinforcement. And do you feel like, given your practice that you guys end up talking to patients, does that add an extra layer of confidence in the patient? When a physician or somebody from the healthcare team reaches out to a patient, it adds that extra empathy, and they're really paying attention, and they're keeping track of what's going on with me.
You bet. It's really important. Our patients like us for that.
Right.
The pharmacy called me. Why? The pharmacy's never called me. Well, we do. It's the practice is calling you, and because of that, they feel like we're paying more attention to them, and we are.
And as institutions start using more of these mobile technologies, we all need to stop and think what we're going to do with this information. So if you have someone saying that their nausea and vomiting is out of control on day 2 or day 3, and that information is then coming to a nurse, then there needs to be protocols in place to clearly define what they're supposed to do in that setting to really minimize the amount of communication back and forth between the doctor. So just something to think about as technology continues to grow.
We've kind of set up algorithms. Whoever's making the call out, if this, do this, if this, do that, if this, do this, and it's all documented that you know, the call is made, everything good, check. Not good, physician called, NP called, whoever it was.
We've done the same thing, and you know, we're in an era now where many of us are participating in the oncology care model and other types of alternative payment models where the locus comes back to us, and that we have to control costs by reducing emergency room visits and reducing hospitalizations. And CINV is a perfect area to work on, because if you have this communication, you have an algorithm, then you know how to deal with it. If you reach out to patients, if they need hydration, they can come into the office as opposed to showing up in the ER, which, as we all know, usually means an automatic admit, because they're not used to dealing with cancer They hear cancer and they get nervous, so we better put you in the hospital. It costs a lot of money for something that doesn't need to happen if we have a focused way of taking care of the problem. And we communicate with the patient. So we get the information and then we deal with it, whether it's done mobily or through a telephone call. I think we'll see more of that in the future, and I think that'll be very good for the patients and they'll care.
It'll really also lend itself to better research and outcomes, because historically, nausea and vomiting is so hard to document because it's underreported. You know, looking back retrospectively, it's really hard to get meaningful data out of that.
And nausea is subjective, so you can't point to, it's not a lab test that we can point to and document.